Sorry.
Okay, so this one just needs to switch on.
So it'll be
This one switches on. You don't need to listen to that radio screen. So you just can hold that confidently like a TV presenter. Okay. Alright, so now we have the green team.
Alright, good morning everyone. My name is Ellie. These are my colleagues Samir, Emma and Nathaniel, and together we're the green team. So we've developed and tested a medical device with promising in vivo data to improve the diagnosis and prognosis of blood clot related disease. So we are asking for £3 million. We are asking for £3 million for a 25% stake in our company, which will give us the backing we need to work towards approval status and eventually improve the quality of life for a huge number of people just like you and me. So let me give you a bit of background information. Today we're going to talk to you about some of the biggest killers in the UK. The biggest is heart disease, causing 27% of all deaths, with most of these occurring from a heart attack. Full strokes are the fourth biggest killer in the UK and leave many they do not kill with life-changing disabilities. Severe diseases such as these are caused by the flow of blood being disrupted, usually by a blood clot, causing local oxygen levels to drop and kill cells in the area. This insufficient blood and therefore oxygen supply to organs and tissues is referred to as hypoxia. It is this that can kill or lead to disability. There is also a chance of patients having strokes during surgery, especially surgery of the heart, head or neck, and patients who are bedbound in hospital are also a higher risk of DVT. This contributes to a problem in hospitals and medical centres where patients are at risk of suffering hypoxia-mediated diseases. So we present to you the solution, a medical device that detects blood clots in real time and a technology brought to you by Quorum Biosense, the clot spotter. I will now hand over to my colleague Emma so she can explain exactly what this is.
Hello everybody. So this is going to be a nanoparticle biosensor. So we have a radio wave emitting nanoparticle in the centre of a PG coated nanoparticle. And this is less than 500 nanometers in diameter, which means it's very small, will not get stuck in any capillaries. It is actually much smaller than a red blood cell, so itself will not contribute to any clot. It has a 12-hour half-life, which means that it will last for the duration of most operations, and it will be excreted naturally through the urinary tract. So this is how it works. You can inject the biosensor in a cannula, which you already have in when you have an operation, and the patient will be lying on top of a radio wave detecting sheet. And this will send data through to a monitor, which will display the blood flow in real time. The program is the intelligence behind this concept. It will calculate the normal rate of flow throughout the body, and what it will actually detect is a change in circulation during the operation. And it will detect the nanoparticle buildup when they're slowing down due to a clot, due to the decrease in blood flow. And this actually makes it more reliable, as it takes into account the blood will flow at different rates throughout the body, rather than just using a cut-off threshold. So far we have some academic and preclinical data which shows that Clot Spotter is not toxic and is far better than any current models of detection. So what we want to do is now trial the Clot Spotter in 15 healthy people, and this will allow us to optimise our detection program to use for human circulatory systems and get data on toxicity, metabolism and excretion. And we hope that this data will allow us to progress through to pre-market application submission to bodies such as the FDA. I'll now pass you on to Nathaniel to discuss our business plan.
Okay, so for the market analysis, there's currently no patents on the market for nanoparticle-based biosensors that detect blood clots and exploit the kind of technology that we are going to exploit. So naturally there is a gap in the market where our product, Clot Spotter, can very nicely fit into. Has a number of clear advantages over conventional clot methods such as the D-dimer test and the ultrasound. And again, in our figures on a couple of slides ago, we were able to see a dramatic increase in the percentage of clots detected. Naturally, if we can detect more of these blood clots, it will lead to better prognosis for these for patients. And of course, there's an ever-increasing burden of these diseases. Stroke kills 1 in 4 in the United Kingdom, coronary heart disease kills 1 in 8 in the United Kingdom, and projected deaths from these diseases are expected to increase in the future. So we can deliver value to patients, but of course we can also deliver values to our investors and shareholders in the company, all of which are very important. So for the strategy and implementation, we will need 6 months to recruit healthy patients for the human trials, so of a range, genders, and also ages, to try and get, as broad a representation as we can of, the population dynamics. We'll need 18 months to collect and then analyse that data. And of course, this data will give us vital information how Clot Spotter behaves in humans, so we can account for circulatory behaviour. Naturally, human circulatory system is somewhat different from that of mice. So far, we haven't tested on humans, so we can optimise our programme to account for that, and also ensure that Clot Spotter is basically goes, the distribution, metabolism, and excretion are as they should be. So financial plans and projections, based on our budget, which you'll see on the following slide, we believe that we will need 2.75 million for this early human trial development, where we're testing on those 15 patients. With this 2.75 million budget, we've accounted for $500,000 in contingencies, should give us a robust budget. But we want to actually request 3 million, and want to request 3 million to account for any underestimated costings, to be extra secure that the money that we will receive will be enough to see this trial through to the end and then progress. So naturally, we will have to test this on more humans. 15 will not be enough. So to move towards late stage development, we expect that we may need around the region of 3 to 5 million, which we're not asking for today, of course. But naturally, we can't predict exactly how much this will cost, because it will depend upon the results of this early trial. If the early trial results are promising, then we would expect projected costs for late stage development to come down considerably. For intellectual property, we will of course hire a patent lawyer and ensure that an appropriate NDA is in place. For exit strategy, we've already had quite a lot of interest from medical device companies, Philips Healthcare, Abbott Vascular, and the Association of British Healthcare Industries. So at this early stage, we've already had interest, and we think interest could further increase because of the market potential of our product. And of course, when our product is eventually approved, we certainly hope it's approved, we would intend to sell it to the highest bidder. Now, of course, it's the cost of the product naturally will be dictated by how well it performs in the early and then late stage trials. Of course, the better our product performs, the more we would be able to expect to sell for it, the more we would expect to be able to charge for it. But until we get that data, it's extremely difficult for us to come up with a concrete figure for, the price of our product. It will very much depend on how it performs. But we think we want to emphasise the market potential of the product. These diseases are killing ever-increasing numbers of people, and there is a clear gap for our nanoparticle-based biosensor with clear advantages. So while I appreciate that we can't give you a concrete figure on the price, obviously of the product, we're confident that it will deliver sufficient returns for any investment. I'll hand over to Samir, who will talk a bit more detail about our budget.
Thank you, Nathaniel. So where did we come up with this £3 million figure? We did all our market research and made our business plans, as Nathaniel mentioned previously, and we looked at similar companies that had devices that had gone through stages of development, and we looked at their costings and made our projections based on this. So I'm not going to go through the list one by one, but it includes staffing for lawyers, nurses, technicians, we pay patients, And as Nathaniel said, importantly, we have contingencies in place which we think will make our budget robust enough to get us to where we want to be. So where is it that we expect to be once we achieve approval status in the future? And an important question to answer for you investors in particular is whether ClotSpotter can be commercialised. And the way that we want to do this is through developing the technologies so that it can become mass produced, which obviously make it much more affordable. So the way that we're going to develop this mass production is through organisation of the materials by making them interchangeable and replaceable, stockpiling components so that we can buy in bulk, which will save money, and then getting offers from various manufacturers, making pre-production samples to ensure that our product isn't hampered in any way by the improving of the affordability. An important point though is that if we're going to mass produce this product, then it requires mass consumption. And we believe that there's many applications that ClotSpotter can help with, and so I'll name a few now. The first being using ClotSpotter in hospitals for a routine screening platform for early diagnosis of ischemic disease. Now, this could be, for example, useful, as Ellie mentioned earlier, for patients that are undergoing surgery, where we can use it almost like a heart rate monitor to make sure that this increased risk of stroke is easily diagnosed. Alongside this, comatose patients or bed-bound patients are more likely to get DVT, and we can detect that a lot easier. Even further down the line, we think we could make this even better applied if we combine it with therapeutics, because if our nanoparticles are going to be at the site of the blood clot already, and if we can then use those to treat the clots themselves with vasodilators or anticoagulants, then we think that can make it even more valuable. Thirdly, this is something quite different, but I think it shows that there's lots of applications for our product, is that 10% of people that undergo long-haul flights actually get blood clots in their legs. And often this is symptomless, but in particular with people that are at high risk, they can get DVT and even pulmonary embolisms. So I hope this emphasises the many uses of our product and will ensure that you investors get a healthy return on your investment. Thank you everyone for listening.
Excellent. I have just a quick question. Did you ask any doctors about this?
No.
I believe you sent us an email saying that you had asked a medical professional who said that the hypoxia and stroking out on the table is actually a very big problem in the medical field, especially with people that are high risk, or those that are more older, overweight, and types of surgeries that are needing more increasing with the increased ageing population, people that are obese, or people that have diseases such as diabetes.
Right. Dragons.
So I just talk you through your idea. So it's a nanoparticle that you inject into a patient. They have to lie on a special sheet and there's a monitor to track it.
Yes, so essentially our nanoparticles emit radio waves. So with the screen that's over the patient, you can essentially detect the nanoparticles by following the radio wave radiation, and it's recorded on a monitor. Naturally, where those particles are moving rapidly through normal circulatory flow, that will be our background essentially, in normal circulation. Where the flow of the nanoparticles is slowing because of a blood clot, there will be a difference in behaviour. We'll be able to pinpoint that difference and track it. So it's all, the basis is the radio wave emission from the nanoparticles.
So you'd be wanting the NHS to buy your nanoparticles, the sheet and the monitor?
The monitor and the sheet would be highly reusable. So they would buy the initial equipment, and then after that it would just be the injectable nanoparticle.
So you're going to have to make sure that they stack up against ultrasound, which hospitals will already have. Is it really a medical device if you're injecting it into a patient? How's it excreted and toxicity?
Well, we have a half-life of 12 hours, but with our studies on mice, there was no toxicity. And naturally, a question in some people's minds is that if you're going to get nanoparticles building up at the site of a clot, could that not exacerbate a clot? but no such behaviour has been observed. There's no, at least in our mice models, there is no acute toxicity, and compared to conventional methods, and we have tried ultrasound and various other methods, we do get much greater sensitivity with clot spot. So we can be confident that if there's a clot out there, we're much more likely to detect it with our product as opposed to a conventional method.
You do say as well that you've got a PEG code, so there is no immune response.
Yes, exactly. Yes, so the PEG code is non-immunogenic, biodegradable, because obviously naturally if we're going to be injecting these nanoparticles, the last thing we want is for them to prompt an immune response, but we can consider them as like stealth nanoparticles in the way that they slip by the immune system unnoticed.
There have been some clinical trials recently where they've used pegylated proteins and the PEG element has caused an adverse effect in humans in certain groups, so just be wary of that.
Okay.
Me? Okay, right. An observation first of all. I really like the way on the very last slide you said, where can this be applied? If you're pitching again, I suggest you put that on the second slide, because all the way through I wanted to know, I understand the problem, I understand the device, where will it be applied, and you came to the end. Let me make sure I understood correctly. So this is going to be used in clinic, in a hospital, is that right? Yes. Okay. Yeah. So I like the way you segmented the market at the end. I may have misunderstood, but I could see a potentially large application of, DVT, pre-flight, all that kind of thing. Surely I'm not going to go into a hospital to have this done before I jump on an aeroplane. I'm just trying to understand the practicality of this.
Sure, no, that's correct. But we'd wonder whether, if someone was at high risk,
Yeah.
and possibly like in their genes and things like that, then actually maybe they would pop into the clinic just to have this injection. And then, I mean, it would be different with the sheet and the detector, obviously, to get on the fly, but we could develop it such that it would be compatible with that.
Yeah.
That's
There's
what I was
also
thinking.
medical tourism, where people go elsewhere and have treatments and operations and then fly back. So it'd be perfect for use in them as well.
Yeah, I guess what I'm suggesting is that the third application, which could be a large market, it might be a relatively small niche within that, because of the hospital part. I had one other question. Yes, that was it. I'm not an expert at all on health economics. I think you've articulated to me what the benefit of this is. I get that. I think health economists also think in terms of cost. So have you thought about, have you spoken to any health economists in terms of the costs of not doing this? In other words, the money that would be saved by the NHS as a result of implementing your product. Have you had any of those conversations?
We haven't, but equally, because strokes and heart attacks and everything are so much more common and they're having such a big effect on people in terms of life-changing disabilities. And DVTs can result in a great many things, including actually amputation of limbs. So in longer-term healthcare, it could save them a very large amount of money later on in these people's lives.
Yeah, the general principle I get, I think enumerating it in terms of money and in terms of alternatives would probably be the case really well. Thank you.
Yeah, really quick. Your licensing option is your best option, but I was just a little bit worried that you won't really see efficacy in your clinical trial because you're using healthy people, so you're just checking that it's safe and well tolerated, blah blah blah, and the process works and things like that. So I just wonder how likely it'd be that one of the larger companies would pick it up at that stage because they don't know that it's actually going to work in a clinical population.
Well, I think obviously with the initial human trial, which obviously you through your investment would be funding, you just really want to get an idea of obviously how the nanoparticles circulate, and then also if there is any toxicity in humans. Naturally, with the latter stage of the trials, we would then move on to a much broader range of patients, and also in that case, also people that actually could stand to benefit from this, people with long-standing issues, history of blood clots, etc. But for the initial trial that you'd be funding, essentially it's just 15 healthy volunteers.
Who would pay for the next trial?
Well, it'd be subsequent investments. We would hope that obviously with the results that we would get from this trial, interest in clot spotter would further peak, and then we'd have an even more attractive case for attracting further investment. So again, it very much depends on the results of the trial, and that's why we would not expect you to fund the whole thing straight off. We're trying to do it in bite-sized chunks. So the early trial and then the latter half of the trial, and this is just the first half, the early part of the trial.
Great stuff.
Thank you.